Thank you, Raquel, for this perfect and very complete presentation. After disclosing my numerous conflicts of interest, I will tell you a story, the story of OA physiopathology. Osteoarthritis is a disease which is characterized by the progressive loss of cartilage. Cartilage, this is the white, smooth tissue that you can see here on the picture in the left panels, which assure the absorptions of the different strain during motions. In osteoarthritis, you have the progressive disappearance of this tissue that lets the subchondral bone appear by transparency. If we look with a microscope at this OA cartilage, we can observe a superficial fibrillation of the cartilage. We can also observe a fissuration that some go through the cartilage to the subchondral bone. We can also observe cell clusters in which we can observe very big cells, which are hypertrophic cells, which are responsible for the mineralization of the matrix. Osteoarthritis is long been considered is a chondrocyte-driven disease, and the chondrocyte, which is the major cells, the cartilage, is in charge of the renewal of the extracellular matrix in the normal conditions. And these cells produce collagen type 2 and aggrecan, which are the two main components of the cartilage. Unfortunately, in osteoarthritis, you have a dysregulation of the metabolism of these cells, and progressively you have a disequilibrium between the catabolic and the anabolic process, leading to the overproductions of metalloproteinases and reactive oxygen species that lead to the destruction of the extracellular matrix and the release in the joint cavity of a lot of product of degradation of osteochondral fragments, which, as we will explain you, will trigger synovial inflammation. Chondrocyte is a resting cells, which in the normal conditions is a very low rate of proliferation. Under the influence of mechanical stress and inflammation, these cells start proliferating and form a cluster, cell clone, which can undergo different phenotypes. Some of them express a catabolic phenotype, other one inflammatory, some repair and resolving phenotype, some senescent phenotype, and finally hypertrophic phenotype. All these phenotypes may exist in the same OA cartilage and may differ according to the localization of the cells in the OA cartilage. Well, then after we discover, and we, the researcher, discover that osteoarthritis is more than a cartilage disease, which can also affect all the joint tissues, including the subchondral bone, and you can observe here at the MRI a particular feature, which is the bone marrow lesions. And at the X-ray, you can also observe bone sclerosis, which is a white line just in regards of the joint space narrowing, which is the result of the cartilage loss. You have also inflammation of the synovial membrane with an hypertrophy of the villosity and the neoangiogenesis of the tissue. And finally, the meniscus are also torn, degraded, and fissurated. Well, if I summarize our knowledge at this stage of the development of OA physiopathology, we can summarize like this. First, you have the cartilage lesions, for example, after a sport injury, which induce a loss of cartilage, and the activations of chondrocytes, which change their phenotype, and some of them are catabolic one, and overproduce some cytokines, mainly IL-1 and TNF-alpha, which may activate the signaling pathway NF-kappa B and Win, which are responsible for the overproductions of metalloproteinases like collagenase, aggrecanase, ADAMTS4, and 5, which are directly involved in the degradations of the surrounding extracellular matrix. More recently, in my laboratory, we have demonstrated that the hypertrophic cells located in the deep zone of the cartilage may also control and drive the remodeling of the bone through the wrinkle release, which activate osteoclasts. Osteoclasts may induce the bone remodeling and communicate with osteoblasts, which are different. The osteoblasts located in the sclerotic part express a fully different phenotype than the neighboring one and overproduce a lot of factors, including IL-6, which can, through the channels, the macroplaques, reach the overlying chondrocytes and by this way may activate them. They also overproduce VEGF, which is responsible for the outgrowth of vessels from the subchondral bone to the cartilage, and the blood arrival to the cartilage induces a mineralization and hypertrophic differentiation of the chondrocyte. By this way, you have a loops between the cartilage and the subchondral bone that justify that we research through inside some drugs used in osteoporosis, drugs to treat osteoarthritis. Another important loops are between the cartilage and the synovial membrane. After the degradation of the cartilage, you have the release inside the joint cavity of a lot of factors, including cytokines, but also damage-associated molecular patterns or senescence-associated secreted protein, fragments of cartilage, product of degradation, but also extracellular vesicle that may directly activate cells of the synovial membrane and mainly cells involved in the innate immunity. Then these activated cells produce in turn a lot of factors which are involved in the cartilage degradation and in the regulation of the chondrocyte. Well, you have well understood that innate immunity play a very important role in osteoarthritis. And this immunity is driven, triggered by a lot of factors coming from the cartilage, including the cytokines, and we have already cited IL-1, TNF, but also IL-6. The complement factors play also an important role, including the membrane attack complex, crystals coming from the mineralized cartilage, also the senescent-associated secretory proteins, including, for example, GRO-alpha, TGF-beta, but also MMP3, and the amphiregulin. And finally, the DAMs, including a lot of fragments coming from proteins of the cartilage, including fibronectin fragments, RNAs, or also type 2 collagen peptide, will all are released in the joint cavity and bind the PRR receptors, including the toll-like receptors and the knot-like receptors, and by this way activate a lot of cells, including type A synoviocyte, macrophage, and T cells. Well, macrophage is probably an important target and a key step in synoviocyte chronicity. In fact, the monocyte may polarize, evaluate to M1 macrophages or M2 macrophages according their environments. And if they are in contact with some factors like LPS or interferon gamma, these macrophage may polarize to M1, which are the pro-inflammatory macrophage, which release a lot of pro-inflammatory factors, including cytokines, inos, and chemokines, while if they are in contact with another set of cytokines, including IL-4 and IL-13, they evaluate and they switch to M2 macrophage, which are involved in the resolving, and these macrophages produce a lot of anti-inflammatory factors, like, for example, IL-4 or IL-10, but also arginase. And this polarization of macrophage was well evidenced in the synovial fluid and in the serum of OA patients. In this graph, you can observe that the number of M1 macrophages, which are labeled by the marker CD11C, are increased in the synovial fluid and in the blood of knee OA patients, leading to an increase of the ratio M1-M2 in the synovial fluid and in the blood of these patients. But what is very important is that these authors in this study have also demonstrated that the ratio M1-M2 is not only increased but well correlated with the Kellgren and Lorentz score, which is a radiological score of OA severity. More the ratio is high, more the severity of OA is. Well, I think that now you are aware that osteoarthritis is associated to a local inflammation, but also to a systemic inflammation. And this was well illustrated by this study published by Bei Jensen, in which they have measured in the blood of the patient CRP and CRP-Hem. CRP-Hem, this is a metabolite derived from the MMP degradation of CRP locally in the tissue. And what you can observe is that in OA patient, the level of CRP and CRP-Hem is over the reference, the clinical laboratory reference, and these factors are increased, but of course to a less extent than in RA patient, for example, the moderate severe or the early RA patient. But what they have also observed is that 50% of these patients, if we rank them according to the level of CRP and CRP-Hem, 50% of these patients have a level of CRP which is identical to that you can observe in RA, with moderate to elevated level of CRP. And this was exactly the same for CRP-Hem. 30% of these patients with knee-OA have a high level of these systemic factors of inflammation. What this means? This means that first, OA is associated to systemic inflammation, and that patients with moderate to very high CRP-Hem level were 2.2 times more likely to develop OA in the knee with no OA at baseline. This is a markers that predict the appearance of the disease. Well, the link between OA and obesity and meta-inflammation was first reported by Grutel and collaborators. Surprisingly, they have observed that an association between the BMI of the patient, the OA patient, and the risk of symptomatic osteoarthritis. And this relationship was well illustrated for knee OA. You can observe that the patient with the highest BMI has a higher risk to develop a symptomatic OA of their knee. This is easy to explain because knee is a weight-bearing joint, and more you load this joint, more you have a risk to develop osteoarthritis. But what was very surprising is that they have also demonstrated that obese patients have a higher risk to develop hand-OA. And we cannot explain that by overloading of the joint, of course. How can we explain that? And the recent research has demonstrated that the white fat of the obese people which are invaded by macrophage, and mainly M1 macrophage, release a lot of pro-inflammatory factors in the bloodstream of the patient that may influence the cartilage degradation, but also the inflammation of the joint. A second important discovery is that the obese patient and the levels of adipokine, which are factors released by the adipocyte coming from the fat of obese people, increase with a BMI, and the set of adipokines that increase are cytokines that have been that have been demonstrated to directly increase the degradation of the cartilage, but also the inflammation of the synovial membrane. While in parallel, you have a decrease of adipokine, which has more anti-inflammatory properties, like, for example, adiponectin. What this means? This means that you have a relationship between the fat, the inflammatory fat in obese people, and osteoarthritis. I have tried to summarize the complexity of the disease in this picture, in this planetary picture. In the center, you have, of course, osteoarthritis, and you have two orbits, the blue one and the red one. The blue one starts with the pain, the mechanical pain. This is the characteristic of OA patients. They have pain when they move. And this pain during motion induces fear of motion, what is so-called the kinesiophobia. Kinesiophobia leads to disability that is responsible for sedentarity and physical deconditioning, which I remind you is the cause of cardiovascular diseases. And this physical deconditioning is responsible for anxiety, depression, psychological deconditioning, which are altogether amplifiers of the chronic pain. The secondary orbits link the metabolic syndromes with the osteoarthritis. It was recently demonstrated that the metabolic syndromes in a whole, or each determinant individually, may directly increase the incidence and the progression of osteoarthritis. And recently it was demonstrated that synovitis in OA joints may contribute to what is so-called inflammaging, which is directly involved in the physiopathology of some cardiovascular disease. What does this mean? This means that now, when you treat OA patient, you have also to treat the comorbidity. You have to consider as a holistic manner your patient. Well, based on that, we can now distinguish different subtypes of OA patients. At this time, we can distinguish 6 different phenotypes. The mechanical injury driven, the aging driven, the cartilage driven, the metabolic driven, the subchondral bone driven, and finally, the synovitis driven osteoarthritis. Different types of patients. And these phenotypes are associated with different endotypes. And if I look at the synovitis-driven phenotype, this phenotype is associated to 3 endotypes: high level of local inflammation, high level of systemic inflammation, and activated macrophages, neutrophils, the innate immunity. And these different endotypes may be characterized by some biomarkers. And if I take just an example, for example, the high level of local inflammation can be characterized using markers like COL2-1 nitrated, C1M, ERANs, or endostatin. Well, this disease is a very important disease that affects at this time 500 million patients over the world. It is estimated that 1 in 4 adults aged 40 and over were affected by this disease, and we can speculate that in 2032, 1 in 3 adults will be affected by this disease because of the aging population and the rising obesity rate. It's right that osteoarthritis is associated to aging, as you can observe in this picture, and mainly after 45 years, and mainly in women after the menopause. The main cause of osteoarthritis are aging, to be a woman, but also to be overweight or obese, and to have joint trauma. This is for which you have to focus your attention on the modifiable risk factors, including overweight and joint trauma, which can be used to prevent osteoarthritis. This disease induces a lot of cost, and just to give you an example, in the US each year, osteoarthritis costs 137 billion, including 66 billion in direct healthcare costs and 71 billion in annual earning losses, which induce each year 181 million of total lost workday. This is huge, and this is for which we have to well treat the patient. Can we prevent this disease? Yes, we can. Yes, we can. And we can first by encouraging the patient to change their lifestyle, to start physical activity, diet, by also to prevent and to treat the comorbidities, to weight loss if required and to maintain the ideal weight, to avoid injury and to treat them properly if this is the case. For example, in a young people with a trauma of the joint, don't encourage them to go to the sport field before to have a well-driven rehabilitation. What is also important is to restore and maintain a muscle function, not only the strength of the muscles, but also the motor control of the muscles. And finally, to correct joint alignment if you have misalignments of the joint. How can we treat osteoarthritis? Just to summarize the current treatment, I would like to share with you the ORC recommendation, because these recommendations are very interesting, because this was the first time that an association recommends modalities treatment for the knee, hip, and polyarticular osteoarthritis, and according the presence or not of comorbidities. And they have written recommendation for OA patients with cardio-intestinal comorbidities, cardiovascular disease, if they are friendly, and if osteoarthritis is associated with widespread pain and depression. They have ranked all the modalities according the level of evidence found in the literature, but also according the vote of experts. And they have ranked the modalities in 7 levels. And they have also give a conditional recommendation or a strong recommendation according the level of evidence, but also the presence of adverse effect related to one particular modality. Well, for this association, but also for the majority of the association in the world, the core treatment of osteoarthritis, this is first education on osteoarthritis, therapeutic education. Secondary, to prescribe structured line-based exercises program, including type 1 exercises, which are muscle strengthening and or aerobic cardio exercises, and or neuromuscular control exercises, and also type 2 exercises, which include exercises combining body and mind, like, for example, Tai Chi and yoga. And the third element of this core treatment, this is dietary weight management. This core treatment is recommended for all OA patients, whatever the severity of the disease, whatever the age, whatever the health status of the patient. Of course, then after you can help the patient using pharmacological modalities. And I would like focus on the knee OA because I have no time to share with you all the recommendations, and focus on the place of NSAIDs in the management of OA. First, you can see that the level 1 of pharmaceutical modalities, which is strongly recommended, this is topical NSAIDs. No oral NSAIDs. Topical NSAIDs for the knee, but also for the hip and the hand. And use of oral NSAIDs was conditionally recommended for individuals with knee OA who do not have comorbidity condition. For example, don't use NSAIDs if your patient is cardiovascular and are friendly. NSAIDs is also can be used, but they can be used during, and I will remind you that later, if the patients are in the flare of the disease and at the lowest concentration and for the shortest possible duration. Finally, you can see that the corticosteroids are only recommended conditionally and not recommended if OA is associated with a widespread pain and depression. You have well understood that one of the therapeutic targets is to limit NSAIDs consumption in OA management. Why? First, because OA is a long-term progressing disease. OA occurs in elderly people with a lot of potential comorbidities, and NSAIDs consumption for a long duration may affect these comorbidities, may worsen these comorbidities. The effect of NSAIDs are also very low, and very low, below, for example, the effect expected by physical activity. They induce severe adverse effect, and finally, they have a high risk-benefit ratio. This is for this reason you have to limit the use of NSAID in the management of OA. I remind you that you have to use NSAID only during the flare of osteoarthritis, when you have inflammatory flare that you can recognize by appearance of pain during the night, but also an increase of pain intensity during the motion. And I remind you that you have to use these NSAIDs at the minimal efficient dose and at the shortest possible period. Well, ORC has also delivered an algorithm, and I will show you the algorithm for the knee OA. For whole patient, you have to assess your patient. After assessing this patient, you have to select one or more treatments of the core treatments: education, exercises program, and dietary weight management. And you can associate it pharmacological modalities, but the primary line is the topical NSAIDs. You reassess your patient is needed. If you reach the objective, if you and your patient have an acceptable pain and improvement of the joint functions, you can maintain the current treatment or stop it, or if this is not acceptable, you can add to the treatment oral NSAIDs, intra-articular injection of corticosteroid or HA, duloxetine only for the OA patient with a depression of cause. You can also add non-pharmacological modalities, including aquatic exercises, gait aids, self-management, and cognitive behavioral therapy. If the treatment is not yet acceptable, then you refer to a pain clinic or to an orthopedic surgeon, and you reassess the patient regularly. What will be the future? The future will be probably the biologics, not only the monoclonal antibodies. You know that a lot of them and a lot of clinical trials collapsed and their developments were stopped. But I think that probably the success will come from what is so-called the advanced therapy medicinal product, the ATMP, which we can classify in 4 categories: the tissue engineering product, the TEP, the somatic cell therapy medicinal product, the CTMP, the gene therapy medicinal product, the GTMP, and what is also called the combined ATMP, which combine medical device plus TEP, CTMP, or GTMP. In OA, this biologic can be classified in 2 groups according their route of administration: the systemic biologic administered by oral, subcutaneously, or intravenously, and you know the biotherapy using monoclonal antibodies, growth factors, or also, and we will discuss that later, enzymes like trypsin or bromelain. And you have a particular category which are so-called the orthobiologics, which are biologics which are directly injected in the joint. And probably that in the future you will see appear a lot of peptide or also extracellular vesicle like exosome, for example, new viscosupplementation. And you will have a lot also of ITMP, like, for example, scaffold to repair the cartilage. Recently, a list of medicine that were assessed by the Committee for Advanced Therapy of the EMA have proposed a list of recommended ATMP, and you can observe that in this group you have autologous chondrocytes combined with autologous cartilage, which are indicated for filling cartilage defect. You have also expanded autologous mesenchymal stem cells isolated from adipose tissue, which are recommended for cartilage defect of degenerative origin and for the treatment of OA. You have also plasmid expressing a variant of human interleukin-10 for the management of pain and improving physical function in the patient with moderate to severe OA. And you have finally, and surprising, allogenic gingival fibroblasts for the treatment of gonarthrosis. Well, I can say in conclusion that osteoarthritis is a serious disease for which there is no cure at this time. You can manage the symptoms, but you cannot cure the disease. You have well understood that OA is associated not only with chronic local inflammation, but also systemic inflammation that play a key role in OA physiopathology, and that, of course, chronic inflammation have to be treated using well-tolerated and safe products. At this time, you can manage inflammation using locally a cold pack, cold therapy, for example, topical NSAIDs. You can also use the NSAIDs, but according to the recommendation I gave you before. There is also a lot of food supplements, including, for example, products based on curcumin, Cisadoa, including glucosamine, chondroitin sulfate. You have also intra-articular treatment to manage this inflammation, like corticosteroids or PRP. Even this late modalities is controversial now. And you will have in the future a lot of biotherapy, including monoclonal antibodies, neutralizing both IL-1 alpha and beta. You will have also sustained release biomaterials, sustained NSAIDs and corticosteroid release biomaterials. Gene therapy targeting IL-1RA is also in the pipe now. Mesenchymal stem cells, which produce anti-inflammatory factors. Microvesicle like exosome are also in development. Enzyme therapy, and of course, lifestyle diets. For example, Mediterranean diet is now under investigation, and some studies have demonstrated that you can protect cartilage using this particular diet. Thank you very much for your attention.